Hello, my name is Savannah Steele. Today we're going to be talking about heart failure, a community-based program clinic for the elderly. This is our table of contents of the things that we're going to be discussing during this presentation. You can take a minute to read over these for yourselves. Firstly, we're going to define heart failure. What is it? It's a condition in which the heart cannot pump sufficient blood to meet the body's needs. And it also includes an ejection fraction of less than 40%. EF less than 40% with current or previous signs and symptoms of heart failure are referred to as having heart failure with reduced ejection fraction. Common causes of heart failure include coronary artery disease, diabetes, hypertension, and smoking. Signs of heart failure include fluid backup in the lungs, buildup of fluid in the lower extremities, which is also called edema, tiredness or fatigue, and shortness of breath. Age-associated changes with heart failure include myocardial and vascular wall stiffness with a consequent increase in aortic impedance may lead to increased end-diastolic pressure and a stiff ventricle resulting in pulmonary edema. Age-related AFib, uncontrolled hypertension, COPD, and other comorbidities are more likely to trigger heart failure decompensation. Comorbidities associated with CHF. 2/3 of elderly patients with heart failure have more than 2 non-cardiac comorbidities. Over 25% of them have more than 6 comorbidities. Diagnosing heart failure. Heart failure can be diagnosed by doing an echocardiogram to show the ejection fraction, a full history and physical, a chest x-ray, and then lab work including a CBC, a creatinine, electrolytes, and a BNP. Risk factors for heart failure are greater than 65 years of age, African Americans, overweight, and history of MI. Cost of heart failure to the healthcare system per year is over $2.8 billion per year, which affects the community greatly. Heart failure is associated with a high mortality rate and frequent hospitalizations. About half of hospital readmissions are related to comorbidities, polypharmacy, and disabilities associated with CHF. CHF also has an enormous cost in terms of poor prognosis, with an average 1-year mortality of 33 to 35%. More than half of patients with CHF are over 75 years of age. Levels of prevention include primary, secondary, and tertiary. Primary prevention refers to the process of altering susceptibility or reducing exposure to susceptible individuals and includes general health promotion and specific measures designed to prevent disease prior to a person getting a disease. So basically, you want to prevent the disease before it occurs. Secondary prevention is the early detection and prompt treatment at the earliest possible stage. Tertiary preventions are implemented during the middle or late stages of a disease, and you want to alleviate disability and restore effective functioning. So for our program, we're going to be functioning at a tertiary level. So our action plan will include education of the importance of adherence, treating the underlying cause, symptom management, mind-body skills, telehealth, and a cardiac rehab program. Also for education, you want to discuss fluid restrictions and weighing daily to prevent the progression of the disease and for management. For treatment, we want to treat the hypertension, the CAD, the diabetes, whatever is causing the heart failure. Program introduction. The purpose of our program, a DNP-led interdisciplinary approach to a tertiary prevention strategy for treating congestive heart failure. Design. To provide treatment options at a tertiary level and education. It will be DNP directed, community-based, and staffed by volunteers and healthcare professionals. Our interdisciplinary team will include a DNP program director, healthcare staff including nurses, dietary specialists, and nutritionalists, support staff including public relations, financial planner, and administrative, a cardiologist, pharmacist, physical therapist, and volunteers. The purpose of the team is to promote heart failure education, provide access to healthcare professionals specializing in heart failure, access to screenings, manage funding for the program, and help with medication reconciliation and filling prescriptions. The pharmacist role. Heart failure patients are on multiple medications that can change frequently, therefore medication reconciliations are important. MedRx can increase adherence, reduce admission, and cut costs to the system. Also, we can identify and prevent drug interactions, and we want therapy optimization. Heart failure medications tend to be under or overdose, so pharmacists can help us find that balance. Medication non-adherence. Medication non-adherence leads to increased hospital admissions, emergency department visits, and complications, including death due to exacerbations. According to a study, there is a 23.5 non-adherence rate, and it is more common among rural and uneducated patients. A study examined heart failure patients visiting the adult cardiology department of a tertiary care clinic and that's where we get our non-adherence rate. You want to be aware of things that can affect adherence, such as being a minority, living alone, having multiple comorbidities. They may need more clarification and more education. So we'd want to focus in on those things. Commonly prescribed medications. We've got diuretics such as Lasix and torsemide, beta blockers such as atenolol, MRAs, antithrombotics such as warfarin and aspirin, inotropic agents such as dopamine, dobutamine, and noradrenaline, nitrates such as isosorbide dinitrate, ACEs, and then ARBs. Here's just a picture of an approach to the treatment of systolic heart failure. Common side effect of meds. Hyperkalemia, hypotension, and renal dysfunction are all common side effects of the medications that these patients are prescribed for heart failure. So we must monitor for these things by periodically drawing labs and doing vital sign checks. Patient education and training. We want to educate these patients on their medications, diet, exercise, sleep, stress management, group support, mind-body skills, self-compassion, and loving kindness. The compassionate approach to lifestyle and mind-body skills for patients with CHF consisted of 8 weekly visits focusing on patient education about medications, diet, exercise, sleep, stress management, and the other things I said. And here are the results of the study. Improvements were observed in depression, fatigue, and satisfaction with life. So we will incorporate this theory into our program. We will also incorporate telehealth into our program. Telehealth will be utilized for patients who are unable to access transportation to a clinic or cannot come frequently for other reasons. A model with a 20-year time horizon to analyze the cost effectiveness using the original study and various data sources was used. It demonstrated that home telemonitoring and nurse telephone support are viable solutions to support patients with chronic heart failure. They were shown to improve the survival of patients and they're cost effective. It showed that the number of days lost due to heart failure readmissions was significantly lower. In a long-term follow-up study that assessed whether an initial 6-month telemonitoring program compared with usual care would result in mortality, heart failure admissions, and heart failure cost. It didn't really have a significant effect on mortality, but the heart failure readmissions was significantly lower in the telehealth group. Telehealth in the elderly. Studies have shown that the elderly are capable users of technology and have similar good outcomes as the younger cohorts. We will also incorporate a home-based cardiac rehab program. This shows improvement in physical capacity and functional status and a reduction in hospitalization. A study with veterans showed a home-based cardiac rehab program is an effective alternative to a facility-based. Patients who completed the program showed improvement in physical capacity and functional status. Hospitalization for heart failure was reduced after completing this program. So that'll be good for our patients that don't have access or the funds for an inpatient rehab program. Palliative care will also be a part of this program. It will be aimed at improving quality of life with advanced disease. Attention will be to social and spiritual needs, symptom management, patient and family education about the course and prognosis of the disease, and then discussion will be placed on the decision of CPR, A&D, and DNR. Symptom management includes O2 for dyspnea, CPAP for sleep disorder breathing, opioids for pain, and SSRIs for depression and anxiety symptoms. The role of the DNP: leadership, foundation of the program, and leading the organization. Collaboration with the patient-family interdisciplinary team, communication of ideas and the plan of care with the patient, and then educating the patient on the plan of care, expected outcome, medications, whatever needs to be educated. These are all leadership competencies necessary for the DNP in developing and implementing the plan. Program evaluation. We'll do an independent study compared to local run heart failure clinics. We will evaluate hospital readmissions and evaluate patient adherence to medications. There was a study done showing that medication adherence measures are useful tools for improving the performance of health plans. And health outcomes. So in summary, we will treat heart failure at a tertiary level. We will utilize telehealth, symptom management, mind-body skills, and then we will evaluate the program for effectiveness. These are our references. This concludes our presentation. Thank you so much.